Hello, my name is Dr. Shanda Blackmon. Welcome to the Baylor College of Medicine Lung Institute podcast series. We're here to communicate with all of our care providers, our learners, and our community, as well as patients, about how to improve lung health, how to educate you and all of the people around you about ways to prevent lung disease, treat lung disease, and maintain lung health. Hello, and welcome to the Baylor College of Medicine on-air podcast series. My name is Dr. Shanda Blackmon, and I'm the Executive Director of the Baylor College of Medicine Lung Institute. And today, I'm here with Dr. Philip Alapat, who is one of our experts in pulmonary and sleep and critical care. And in fact, he leads the pulmonary fellows and the critical care fellows as they go through their training program. Welcome, Dr. Alapat. We're happy to have you here.
Thank you. I'm happy to be here.
So tell me a little bit before we get going on what your specialty is, which is actually helping people sleep better, helping people breathe better while they're sleeping, and enhancing that quality of air exchange at night. Let's talk a little bit about how do you train to be a pulmonologist?
Sure. Well, training in pulmonary and critical care medicine, which is what the program that I run at Baylor College of Medicine, is a training program that trainees have to train first in internal medicine for. So after medical school, a 3-year program in internal medicine, and then you will do this training program that's usually 3 years, not counting any research time that you may end up doing.
So when people are looking for a pulmonary doctor or a specialist, at what point do they need to come to you as a specialist? Does the average person say, well, I don't feel like I'm sleeping well at night, I need to go see Dr. Alapat? How does that work?
Sure. The usual path is through a primary care provider or some other physician who has cared for a patient and recognized that their ability to address the patient's basic concerns are reaching the limits of their understanding. So the basics of asthma, perhaps COPD, even basics of sleep medicine should be able to be addressed by most initial care providers. So your family practitioner, your internist, your nurse practitioner as a primary care provider should be able to address most things. But when that gets complicated, and that's when the referral is made to the pulmonologist.
Okay, so maybe a primary care provider is convinced that their patient has obstructive sleep apnea, or they're convinced that their patient has some abnormal breathing, or they've had some type of injury that's made it difficult for them to breathe at night. Are these sort of the types of consults that come your way?
Absolutely.
Okay.
And the benefit of having done some kind of workup initially by the primary care provider is of great benefit to the specialist in pulmonary and or sleep medicine, because we are then able to use that information along with the patient's presentation to help our understanding of what exactly is going on and help the patient.
So when you first meet these patients, does everybody immediately go into the sleep lab and go to sleep and get wires and monitors connected to them so that you can collect data, or do you have to decide who's appropriate and who's not appropriate for those types of sleep studies?
That's exactly right. The idea is that not every patient who presents to a sleep medicine clinic can benefit from a sleep study, especially as significant as one that would require you to come to an in-lab facility and spend a night. Mm-hmm. Many times the initial evaluation for something as simple as obstructive sleep apnea is via a home sleep test. And the majority of the time, that is actually able to figure out if the obstructive sleep apnea part is what's contributing to the problem.
So what's a home obstructive sleep apnea test? That's like where you stop breathing at night and maybe you need a machine like a CPAP machine or something to help you breathe at night. Can
Correct.
you do that home test to decide if you need a CPAP machine?
Yes, so the home sleep test is a good test to evaluate for obstructive sleep apnea in someone you really do suspect of having obstructive sleep apnea.
Okay.
It's not a great test to rule out obstructive sleep apnea as the cause, and so that's where that in-lab sleep study may be necessary.
Okay. And then when people come in to have these in-lab sleep studies done, What types of diseases do you diagnose or problems do you find?
The usual complaint is excessive sleepiness or inability to maintain sleep for some reason. So the sleep disordered breathing of all types. And here at Baylor, because we are a referral center, we'll see lots of patients with difficulty breathing for various other reasons other than obstructive sleep apnea. So perhaps it's neuromuscular disease, or perhaps it's some other restrictive thoracic disorder that is contributing to their difficulties, and we're not able to figure out what exactly is going on until there's an objective measurement of various parameters that are measured during their sleep, and then we recognize, oh, wait, there's a problem here, and we need to try to fix it.
So I keep hearing about how dementia and other really neurologic problems are tied to a lack of sleep. So how imperative is it that we get our sleep figured out?
I think if you haven't heard that good quality sleep is a good part of your, ideal health requirements, you're probably not connected
Living
to
in a
anything.
cave.
Yes, something like that nature. So the idea that you need a good quality night's sleep is something that's pretty well entrenched in pretty much everyone's thought processes. But how that is, how it impacts someone, and perhaps when you are sleeping, you are not necessarily aware of what's going on with you. And so something as simple as obstructive sleep apnea can be significantly affecting your sleep quality, and you are not aware of it because you're obviously asleep and not aware of what's going on with your body until somebody else tells you, oh, you're actually stopping breathing while you're sleeping. And that bothers me. And so that's then what prompts that patient to come to the hospital, and then we try to figure out what's going on.
So usually it's the spouse or the children or someone around that's watching this person sleep that notices that they have a problem and tells them to go get help.
Correct. Or the patient recognizes that their daytime function is not as good as it should be, and that they're perhaps falling asleep in inappropriate situations like driving, or say they're trying to take part in a business meeting of some sort, and they find themselves unable to stay awake. And
That's a problem.
It's a big problem, and
Yeah.
that perhaps is the indicator to come to the sleep medicine physician.
So there are a lot of other reasons why people don't sleep at night. Sometimes it's anxiety, sometimes it's menopause, sometimes it's hormonal or stress. How often do you find that some of those other reasons are the cause of not sleeping when they come into the sleep lab? Or how do you figure that out? Which ones are mechanical and fixable versus which ones are not so mechanical?
Yeah, it's usually a process of elimination. So we try to evaluate for those things that we can evaluate for, and then we recognize, okay, well, none of those things are there, and you're still having reported difficulty, then we need to try to evaluate for the other things. And very often, these are things that are not able to be determined by a blood test or a specific other finding. So it is something where it requires a good evaluation by someone who is trained well and is able to spend the time doing that proper evaluation. Something as simple as medications and alcohol or caffeine, or even the side effects of some of the common medications that we utilize can contribute to poor sleep quality.
Can you give me a quick list off the top of your head of things to avoid to help you sleep better and things that might help you sleep better?
It's pretty easy. Pretty much anything that you're going to take to possibly improve your sleep is more than likely not going to improve your sleep. If you're having to put something foreign into your body, it is likely not a great idea over the long term.
So chronic use of melatonin, good idea, bad idea?
So there is probably nothing that will support its use chronically.
Yeah.
And there's very little that supports its use even short term. It is possible that for some people with things like jet lag and those kinds of things, melatonin may be of some benefit, but in obviously very short term use.
And a lot of concerns are coming out about melatonin. And I think the big problem that we all know about is it's not regulated, right? When you go to your average vitamin store or grocery store, it's not regulated by FDA. And so the dosage can vary from 3.5 milligrams to 10 milligrams. And you don't really know if the on-label indication is really what you're taking. And we know that high doses of melatonin can cause a lot of harm.
Yes, it can, and it's purported that this is a supplement that is not that cannot cause any harm, and that's where I think some patients may be led astray.
Yeah. Oh, that's good to know. And then what about magnesium? Does that help at night? Do you know any data about whether or not magnesium helps people to sleep at night?
So again, the data available to support its use for general sleep help is slim to none.
Okay.
So anecdotally, I definitely have patients who will come and tell me that, hey, why didn't you recommend me to take magnesium? Because I am now taking it and I'm sleeping great.
Yeah.
I honestly don't know how it's actually working. It's possible that it may be of some benefit for patients with leg cramps and some kind of muscle soreness and things like that. And even that realm is something that I'm now stating just from anecdotal reports.
Yeah.
So I don't know what to tell you.
Okay, so now we've talked about melatonin, magnesium. I think the heavier sleep aids like Ambien and drugs are definitely to be avoided. I try to get my patients who come to me that are on those drugs off of them before we offer them surgery, because people can be addicted to benzodiazepines and people can be addicted to these sleep aids. And then when they come into the hospital, it's a real problem, don't you think?
It absolutely can be, especially patients who are taking very high doses of these medications and inappropriate doses of these medications. The difficulty is that we just don't have long-term use data for any of these medications.
And what does it do to your brain over time?
Exactly.
Yeah.
And in general, we recognize that most of these medications have adverse consequences. So a good rule of thumb that I've just kind of adhered to as I age more is that if you really don't need a medication, try not to take it. And the hypnotics, that is things like your sleep aids, these medications in general can be used for some benefit for some patients in short term, but for the long term, it's probably not a good idea.
Yeah. Okay, good. Well, I mean, it sounds sort of obvious, but it's really profound if you think about what people are getting hit with advertisement, with, sort of urban legend. Everybody's getting that. And I know, like, for women that are going through menopause, the adding of progesterone, if it's appropriate, they don't have a history of breast cancer, sometimes can help women sleep at night, but that's got to be under the direction of an OBGYN, not a sleep specialist, right?
Correct.
Yeah.
Oftentimes there is some communication that may help a patient lean one way or another, but there are multiple considerations that need to be had when you're discussing hormone replacement therapy. And you're absolutely right, hormone replacement therapy can be of significant benefit for some patients when they're reaching that menopausal state and recognize insomnia as a big concern.
Yeah.
But you have to speak with your OB-GYN doctor or whoever it is that's governing your use of this medication.
So let's move over to the things that you want to try to help you sleep that are okay, or things that you want to avoid to naturally help you sleep. So I think I've always heard about sleep hygiene, creating an environment where you don't have a TV in there, you make the room cool and dark, sort of don't overdress at night. What are some other things that you tell people to help them sleep at night naturally?
Okay, I've heard that don't overdress at night. That's interesting.
Yeah, sometimes women wear too many clothes to bed, and then halfway through the night they get all warm and cozy, and then they're all sweaty, and that's really kind of a bad idea. So okay. I've heard that you should not overdress at night so that you can regulate yourself.
Yeah, it's possible. So there are 3 hallmarks that we always aim for, and that's that cool, dark, quiet environment. Ooh. So if you can aim for those, and you mentioned, I think, all 3 of them in the introduction here, then you're headed in the right direction. So cool, as cool as you can get your bedroom, and I know this because my air conditioning just went out last night. It's a little tough to sleep when it's not cool.
Especially in Houston, Texas.
Oh, yes. And the idea that the cooler the better is actually pretty sound. If you can get your bedroom down to, say, high 60s even, you can actually, it is scientifically proven that you're probably going to get better quality sleep in that cold temperature.
Okay, I'm going to play this podcast for my husband. Definitely. All right. We're
Okay.
always struggling over that one.
Oh, yes.
Okay,
yes.
so cool, now dark.
Dark, exactly. So any kind of light interfering with your sleep at nighttime can possibly disrupt your body's ability to maintain that natural circadian rhythm that's helping you get sleepy as the evening progresses into nighttime, and then get to sleep throughout the night. And then to wake up in the morning with morning light. All that is the whole concept of trying to maintain a dark environment.
And so does that include like a digital screen? Turning on a bright digital screen in the middle of the night seems like a perfect way to ruin your night of sleep.
Possibly. So the light part of it is definitely a component of interrupting your sleep quality, but probably more so if you're turning it on to, say, watch an action movie at 2 in the morning, your brain's ability to kind of settle back down after that movie or when you turn it off is probably it's going to take a while to get back to sleep.
Yeah, I can imagine.
Yeah.
And then quiet. How important is quiet?
Yeah. So the quiet part of it is kind of hard to maintain, especially if you have a family, pets. I don't know, you're in a busy neighborhood in the middle of the city. It's pretty tough. And so,
Or a husband that snores?
Okay, all right. And so multiple factors may be contributing to the lack of quiet in your bed environment. So one of the things that we do support is the idea that a white noise generator can help drown out some of that noise. And the point behind that is that you have noise of equal amplitude in all of the frequencies that your hearing can recognize, then little sounds here and there are not going to be as disruptive to your sleep. And so it's not necessarily quiet, but the level of ambient noise is the same throughout the night with this white noise generator.
Sort of like how when you bring your newborn to a restaurant and it sleeps beautifully through the restaurant, it's all that white noise. There's nothing, if it's in a quiet room and there's a sudden noise, it'll startle the baby and wake them up. But somehow, ironically, you take them to a noisy restaurant and it's just that constant noise that'll kind of keep them soothed.
Yes. Well, I'm impressed you'd have to take them to a fancy restaurant. I would put our kids into a car.
I wouldn't take them into a fancy restaurant, but definitely like a basic restaurant when you can't afford a babysitter. I remember those days.
Yes. Well, those are definitely an issue.
But driving around in a car, sort of the same thing, right? It is sort of quiet in a car, and there's that white noise of the engine running, maybe a little movement that's good. Okay, so let's talk about now more mechanical sleep enhancement. Breathing. How do you help people breathe better at night?
Yeah, so the basic of obstructive sleep apnea is that you have difficulty breathing because some part of your upper airway collapses during sleep. And that's exceedingly common. Probably about 20% of the population will have clinically significant enough obstructive sleep apnea that it's impacting their sleep quality.
Okay.
So if we can try to recognize that early and try to treat it with something that is able to stent open their upper airway during their sleep quality should ideally be improved, and the adverse consequences of not treating their sleep apnea are then kind of removed.
Okay.
So that stenting open of the upper airway is still the gold standard. Is still a CPAP device, which uses airway pressure to maintain that airway patency. But everyone has seen the advertisements at nighttime of a patient wearing a mask and being frustrated with wearing a mask and the air pressure, and that's certainly understandable. And so there are other ways to try to stent open that upper airway, but usually require some type of intervention, whether it's a mandibular advancement device to open up the jaw a little bit, to open up the back of the throat, whether it's surgical interventions, or perhaps even like a nerve stimulator device that may help open up the upper airway. And these are all parts of the sleep medicine world that should be evaluated by a sleep medicine specialist who has options in these therapeutic realms.
So we always talk about the importance of multidisciplinary care, having a complex care group where the providers know one another, like we have at the Lung Institute. How closely do you work with some of our ENT specialists? I know we have a couple of ENT specialists, like Dr. Andrew Wong, who specializes in that implantation of a nerve stimulator that pushes the tongue, pulls the tongue back, pushes the tongue forwards. How does that work?
That's correct. So Dr. Huang and his colleagues in our otolaryngology section will have the ability to not only offer surgical therapies to open up the upper airway, but this hypoglossal nerve stimulator therapy, which aims to try to contract the tongue and some of the muscles around the tongue during early inspiration. So as you're beginning to breathe in, it'll try to contract those muscles to hopefully open up that upper airway, just like we talked about, to maintain that airway space so you can breathe properly.
And snore less?
And snore less, possibly,
Great.
yes.
Possibly. Anything to make the snoring less. Good.
Okay.
Okay. So you work collaboratively with these surgeons to implement the technology that might help them to breathe better by clearing out the airway, relieving obstruction, helping to maybe stimulate muscles to help enhance that breathing. And then you also might prescribe a CPAP machine. CPAP machines, to me, used to be horrific devices for people to put on at night, but now we have new kinds of CPAP machines, right? Can you talk a little bit about that?
Well, the concept is still the same. It hasn't changed. It's just airway pressure.
Okay.
But the devices have become much smaller. They're quieter. The masks are more comfortable. There are more options for masks. And so the majority of patients, if they spend enough effort and time to try to find something that fits and is comfortable to them, can usually gain benefit from a CPAP device if obstructive sleep apnea is present.
Yeah. And so then they're more awake in the daytime. They can read a book and not fall asleep, sit through a business meeting, not fall asleep. Their quality of their daytime is also better in addition to their quality at night, right?
That's correct. And it's often shocking what a patient will understand if they actually have someone show them what they're doing in their sleep and show them how their oxygen level drops frequently during their sleep because of the obstructive sleep apnea, or show them their brain waves, which show that their brain is constantly getting into periods of waking up from sleep related to that difficulty breathing. And when they get that feedback that, oh my goodness, I'm not able to maintain sleep, this is what's been going on every night when I've been going to sleep for the past how many ever years, then there's added incentive to try to get this taken care of.
Yeah. Well, this is great. I mean, it sounds to me like there's so many options out there. There are a lot of things that maybe we try to do that aren't really helping us and might be hurting us, especially the supplements and medications and vitamins and things like that. But then there are a bunch of other things that are good options out there for people who truly have obstructive sleep apnea. What other diseases are out there that you treat that we haven't covered?
Well, we also address those patients who are unable to breathe effectively for various other reasons. So breathing, as you know, is not just your lungs and your diaphragm. There's a lot of other there are a lot of other structures involved, including your thorax, your rib cage, your muscles around your rib cage, your brain, and the nerves that connect your brain to all of those muscles and the diaphragm. So there are a lot of factors involved, and any abnormality in any of those parts can lead to difficulty breathing. And so there are many patients with afflictions that lead to them having difficulty breathing not only during the daytime but also during sleep. And figuring out those problems with sleep studies or with breathing tests helps us determine what we can use to help them breathe better, not only during the daytime but also during their sleep.
So maybe someone who has multiple sclerosis or early onset ALS or other diseases where the nerves aren't working the way that they should, you can help try to get them a better quality of life and diagnose that early and then enhance the breathing at night.
Absolutely. And it often is of great benefit to their function when they present to us and they've been trying to deal with this for patients with some muscular dystrophies have been dealing with this for years, and they don't recognize that they actually could benefit from some type of breathing assistance, especially during their sleep. then when we are able to implement it, they recognize that they can actually do a lot more during the daytime because they've actually gotten a degree of rest that they were not able to get before.
Wow, that's amazing. Yeah, I think about that on nights when I've been on call and I've been up all night. I'm not as useful as I am the next day, especially the older I get.
Yeah.
So when you're treating people with neuromuscular disease and you're trying to enhance their ability to sleep, do you ever put them on a ventilator at night to help them breathe better?
Yeah, so even a BiPAP machine or a bi-level positive air pressure machine can be considered a type of ventilator because it is providing some degree of breathing assistance. And so any type of breathing assistance is essentially ventilator assist, improving your breathing while you're sleeping. And so if you're going by that definition, there are a lot of people who, for various reasons, whether it's just simple obesity itself that is contributing to their difficulty breathing versus the neuromuscular disease patients versus those patients with thoracic or rib cage problems, muscle problems, what have you, all of those patients can improve with some degree of breathing assistance. And whether or not you call it a ventilator or a bi-level positive air pressure device, they're essentially doing the same thing.
Yeah, and I know sometimes I'll see people who have a disease called myasthenia gravis, where they have maybe a tumor in their thymoma, a thymoma or a tumor in their thymus gland, or sometimes they don't have a tumor at all, but they have a disease where the acetylcholine receptors are disrupted and they're not working properly. And when that happens, their breathing is impaired. What do you do for those patients?
It's pretty much the same thing. The interesting thing about myasthenia gravis patients is that they, as you know, have exacerbations that make them have more difficulty during certain periods of time, and then perhaps have no difficulty other periods of time. And so during their difficult periods, they may need the breathing assistance with a breathing machine, and that can be of significant benefit, even preventing them from coming to the hospital, or if they're in the hospital, preventing them from getting intubated, which is that breathing tube in the throat.
Yeah, that makes a lot of sense. And then when we look at patients who have problems such as traumatic disorder, where they're waking up and having problems maybe with their diaphragm, how do you know if someone has a problem with their diaphragm or not?
We can do tests to evaluate their diaphragmatic function, both visually and with breathing tests, but we can also look at a sleep study and try to get a sense of how their breathing function is affecting their carbon dioxide levels and their oxygen levels. And using all of that information, we're able to get a sense of what's going on.
So one of the tests that I will do if I think somebody has a problem with their diaphragm is I'll have them do a pulmonary function test sitting upright, and then they lay down, and we do the pulmonary function test when they're laying down. And we see that when you put that abdominal pressure, pushing the diaphragm up when they're laying down, and then they feel like they can't breathe, that's an early sign that there's something going on wrong with the diaphragm. Another early signal that there's something wrong with the diaphragm is if they get in a hot tub and they feel like they can't breathe, or they get submerged in water where there's external pressure that's pushing in on the chest wall and they become dependent on that diaphragm. They feel like they can't breathe when they go in the water. Those two things sometimes tip me off that somebody might have a diaphragm injury, and maybe I would send them to you to get further evaluation. And sometimes we'll tighten the diaphragm up to make them be able to breathe better a little bit, take it out of the equation.
That's right. That's right.
Again, that multidisciplinary function of working together as providers, where one has a certain skill set and the other has one, and together they can really treat a disease much better than individually.
Correct, and that's the benefit of working here at Baylor, where I'm just fortunate to be surrounded by colleagues such as you and many others who focus in their particular realms, but are also very communicating to others to try to help care for our patients.
Well, thanks for spending the day with us. I feel like I've learned so much about sleep, and I know we're all very concerned about sleep and ways that we can enhance our sleep. And I know I, for one, am going to be maybe referring my snoring husband to you. So have a great day, and thank you so much for joining us. And thank you for joining us at the Baylor College of Medicine Lung Institute On Air podcast.